Welcome, everyone. I think we're very fortunate tonight to have a great speaker, Marc, give us this talk. Welcome, Marc. Marc Carrier is the current Vice Chair of Research and a professor in the Department of Medicine. He's a senior scientist in clinical epidemiology program of the Ottawa Hospital Research Institute. He holds a Tier 2 research chair in venous thromboembolism and cancer from the University of Ottawa, and a new investigator award from the Heart and Stroke Foundation of Canada.
It's really a great pleasure to discuss cancer-associated thrombosis. There's a case study, it's aggressive colorectal cancer from Normand Blais from Recurrent, Montreal. So a 39-year-old accountant, he's married, 3 children, non-smoker, non-drinker, past medical surgical history, abdominal hernia repair and vasectomy. Previous history or family history of cancer, his BMI is 23. And he presents to the emergency room with 1-week history of shortness of breath and cough, not responding to oral antibiotics, has a normal CBC initially with a good platelet count. He has slight increase in his PT and INR, GFR is good. And he has a CA that is 4.8. So the CT scan of the chest showed enlarged metastatic lymph nodes, right hilar lymph nodes, retrocranial lymph nodes, right middle lobe bronchovesicular thickening. He's referred to ENT for a diagnosis and biopsy. A few days later, he presents to the emergency room with new diagnosed right upper extremity swelling and pain for 2 days. He has a proximal upper extremity deep vein thrombosis, so clot in the axillary subclavian internal jugular vein. And that begs the question at this particular point in time, what would you do? Would you hospitalize him? And that's a way to, generate discussion about decision on hospitalization, not necessarily for burden of VTE, but also facilitating diagnosis, for example. Would you use one of the low molecular heparin? Would you use vitamin K antagonists, or would you use one of the direct oral anticoagulants? So this particular case, Mr. NN, he's treated with therapeutic dose low molecular heparin. It felt a bit maybe easier to manage in the perioperative period because you need to have a fine needle biopsy of the right neck that is done on March 22nd, which showed adenocarcinoma from colorectal origin, and then said, he had this C-scope afterwards that confirms the proximal transit colorectal carcinoma. So the next step on April, he has new right upper extremity symptoms, worsening of the swelling. The Doppler confirms extension of the previously described thrombus, so this is risk of recurrent DP despite anticoagulation. It's not unusual, right? We've seen the risk of recurrence, so 1 in 10, 1 in 20 patients will have them depending on the agent. Patient has been compliant with the low molecular heparin injection. That's not the problem. There's no heparin-induced thrombocytopenia. It's a little bit further down the road, but always important to keep in mind. And the decision is to increase the dose of low molecular heparin up to 125%. So there's some guidance from the American College of Chest Physicians that if you're already on a subtherapeutic dose, like a 50% or prophylactic dose, then that's easy. You switch them up to 100%. But if you're already on a therapeutic dose, let's say that you're on low molecular heparin at a certain pre-filled syringe, then the recommendation would be to increase that from 20 to 25, usually the next pre-filled syringes. But it's important to still see your patients. You need to reassess them in 5 to 7 days. Make sure that symptomatically they're starting to feel better, and if so, then you continue the same and you resume your usual follow-up. But if not, then maybe additional imaging down the road might be important. Some of these patients need to see a lot of anticoagulation. They have a lot of non-specific bindings to proteins that can lead to decreased efficacy of some of the anticoagulants that we usually use. The ACCP also has some recommendations. So what if this has happened if you had picked rivaroxaban or edoxaban, for example? There's not a whole lot of data. Some data is ongoing, or studies are ongoing. Right now, the guidance from the American College of Chest Physicians would say to switch to low molecular heparin at a therapeutic dose for at least 4 to 6 weeks and then reassess at this time afterwards.